All right, everyone. We have a lot to get through, so let's get started. Welcome to the WHA Sepsis YouTube series. Today we're going to present on avoiding hydrophobia and the 30 by 3 despite comorbidities in sepsis. My name is Bobby Redwood. I'm dual trained in emergency medicine and preventive medicine. I'm a full-time emergency physician. I treat septic patients almost every shift. I have no financial disclosures, and today we're going to talk about what the 30 by 3 is, who should get it, who should not get it, and whether we are harming patients with fluid overload, and if fluid overload does occur, what to do next. So what is the 30 by 3? If you recall the core elements of the SEP1 sepsis core measure, they are within 3 hours, this is ED care, to measure a lactate level, to obtain blood cultures ×2, to administer broad spectrum antibiotics, and to administer 30 cc's per kilogram crystalloid, usually normal saline, for hypotension or lactic acid greater than 2. Now, it's hard to say 30 cc's per kilogram normal saline when you're talking to your nurses. The slang 30 by 3 is used by quality improvement teams across the U.S. to better facilitate physician communication. I actually like the 30 by 3 language. We use it a lot at my institution, and it streamlines communication. So if you haven't heard 30 by 3 before, you can start using it. Now, who should get it? Just to recall about the core measure, this is using the Sepsis 1 definition. I know that's controversial. We have a different YouTube video on that, but CMS is using the sepsis definition, and it's actually an excellent definition for screening in the ED. The 30 by 3 should be administered for patients who have severe sepsis or septic shock. Those are patients with a lactate greater than 2, signs of end organ damage, or hypotension. There are very few exceptions to people who should get the 30 by 3. The main one, and I think the obvious one, is you want to make sure your patient is actually septic. So we do not want to treat false positives. A common myth about the sepsis core measure is that the goal should be 100% compliance. Really, no one in the nation has 100% compliance with that. If we had a 100% goal with the Sepsis 1 core measure, we would be over-treating patients. The highest performing states are around the 65 percentile in terms of compliance with the sepsis core measure, and the average states are around the 55th percentile. And so we don't want to treat every panic attack that comes through the door, every DKA from medication noncompliance with 30 cc's by kilogram normal saline. That would be overtreatment. But when a patient is truly septic, when they have a source of infection, when they have 2+ SIRS criteria, when they have signs of end organ damage or elevated lactate, we should be administering the 30 cc's by the 30 by 3 pretty liberally, to be honest. If a patient has actual clinical pulmonary edema, that's a time when a fluid challenge may be appropriate. You don't want to make that worse. That being said, even CHF patients who have fluid overload and true sepsis may need the 30 by 3, and we'll talk more about that. We don't want to administer the 30 by 3 in comfort care patients if it detracts from their comfort. And then if the patients have shared decision making with you and they refuse the 30 by 3, obviously we're not going to treat anyone without their consent. These are the ones that are not exceptions. So we do administer the 30 by 3 in CHF patients with sepsis, in end-stage renal disease patients with sepsis, and in the morbidly obese with sepsis. There is a clause, sort of a get-out clause, for using ideal body weight. We recommend that based on the literature if the patient is over 200 kilos. And so your 100 kilogram patient may be obese, but I would still in that case do 30 by 3 based on 100 kilograms, not ideal body weight. So are we harming patients? The literature says no, we're actually saving patients, and that bears true in Wisconsin as well, which we'll talk about at the end. Leisman and all showed that early initiation of IV fluid improves survival in severe septic and septic shock. In fact, what I found very interesting was the sicker cohort actually had improved mortality when they received the 30 cc by kilogram normal saline bolus in comparison to the less sick cohort. So the patient who received early IV fluids tended to be sicker on average, but still had improved mortality. And then we have new Wisconsin-specific data, Rourke et al. This was just presented at the spring conference of Wisconsin ASEP. But they actually, went head-to-head, 1,100 patients and 229 of which were CHF patients. And they found increased mortality if the 30 by 3 was not given, and no significant increase in iatrogenic pulmonary edema. There was longer length of stay if the 30 by 3 was not given, especially in CHF patients. And then this part I found very interesting. Physicians were reluctant to administer the 30 by 3 if CHF label was on the chart. So CHF label is such an interesting thing. We have so many patients with congestive heart failure, but really we should be talking about ejection fraction. And when they surveyed patients or surveyed providers as why the 33x3 was not given, it was often based on that label of CHF, not based on lung exam where we hear crackles, not based on a chest x-ray showing iatrogenic fluid overload or fluid overload in general, and not based on ejection fraction or last echo. And so I think that's important, that most CHF is actually well treated, and if a patient comes in truly septic, even if they have that CHF label, it's important to treat them with the 30x3. Now, if iatrogenic fluid overload does occur, here's what you do. First of all, I always tell people to prioritize fluid resuscitation over respiratory status in sepsis. Okay, so if a patient is cardiovascularly dry, if they are intravascularly depleted, we need to replete them so those antibiotics can get to every corner of their body so we can actually treat the underlying insult. If we don't do that, it's a non-starter, and we're going to see that death spiral of hypotension, septic shock, and death. Now, the key to avoiding iatrogenic fluid overload is to reassess the patient. The whole point of the sepsis core measure is to get us to snap into critical care mode. So you don't just put in the 30x3 order and then wait for 3 hours. You go and assess the patient after 500 cc's, after 1,000 cc's, after 2,000 cc's. You make sure that the patient is getting better, not worse. And then obviously if you see the patient's getting worse, you have a decision to make. Now, I always say have a conversation with your intensivist, even if you do experience iatrogenic fluid overload. Oftentimes, this patient is going to end up getting intubated in the ICU regardless. When we see septic patients with true sepsis and septic shock, after their ICU stays, they are often 10 liters up, 15 liters up, 20 liters up over the course of their ICU stay. So these patients are going to be getting a ton of fluid. What's important is that we play our role as ED resuscitation and really be assertive with that fluid. And then finally, the cure for fluid overload is BiPAP or intubation. So if a patient is truly septic, if their blood pressures are tanking, flood them with fluids, 30 cc's by kilogram, normal saline, or 30x3, and then you can always intubate or initiate BiPAP if iatrogenic fluid overload occurs, which is a rare phenomenon. Okay, this was meant to be a quick hit video. In summary, the 30x3 is safe and should be administered in all septic patients meeting the SEP1 criteria despite comorbidities. You should reassess the patient frequently. You can always back off if you find a reason not to. CHF on the chart does not equal a 0% ejection fraction, so really dig into that CHF history. You want to know a lot about this person's heart before you administer 30x3. If they have a 45% ejection fraction, you're probably not going to run into any trouble. If they have a 15% ejection fraction, you should still administer the 30x3, but reassess frequently. Iatrogenic fluid overload in ED sepsis resuscitation is actually rare. It's highly avoidable with reassessment like we just talked about. And if iatrogenic fluid overload does occur, the treatment is BiPAP or intubation, which we are obviously facile with in the ED and in the ICU. And then finally, this really works. In the end, it's all about mortality. What we see when you initiate the 30x3 in severe sepsis or septic shock is fewer ICU admissions, fewer level of care upgrades from the floor, and fewer crash intubations in the ICU. Most importantly, we're decreasing mortality. If you look at that red arrow, that is when the CMS septic bundle was announced. We saw our greatest drop in sepsis mortality in Wisconsin after that intervention. And here we just got the 2018 data. Between 2010 and 2018, we saw a drop in sepsis mortality in Wisconsin from 25.2% to 17.1%, a 32% decrease. So I thank you all for listening today. I welcome your questions, and good luck treating your septic patients. It's obviously a challenging patient population, and I know that the 30 cc per kilogram or 30x3 fluid bolus has caused a lot of consternation among emergency physicians. We now have 4 years of experience with this protocolized care, and it's doing really well and saving a lot of lives.